To the Department of Medicine Patient Safety Conference. I want to extend a special welcome to our guests from trauma and radiology. Thank you so much for coming. Also see some fellows. We're really glad that you're here, and also colleagues from GI, and thank you all for coming. In pharmacy, good to see you guys. All right, so our purpose in this is to create a forum in which members of a multidisciplinary healthcare team can engage in objective, non-judgmental review of adverse outcomes and commit to systemic process change. So our guiding principles, as a reminder, are to foster a safe, open, respectful environment that facilitates discussion, learning, and teamwork, to focus on systems factors as root causes of adverse events rather than individuals, to look for underlying systems-level causations that were manifest in personnel-related performance issues. And as a reminder, all of this is confidential and privileged. So I wanted to briefly review some of the action items from our last patient safety conference. As you'll recall, we reviewed a case where there was a duplicate order for Coreg, and that was administered and led to cardiogenic shock for a patient. So out of that case, we had 3 action items. And one was to develop a policy where all blood pressure medications require holding parameters. And so I really appreciate Brittany White's work on this, as well as Katie Ray's work. My understanding is that this was put forth to Pharmacy and Therapeutics Committee and was approved. And so the build is happening in Epic right now. So it's done? Awesome. So we can check this one off the list. We've now got hold parameters on blood pressure meds. The next was a need for improved communication between nurses and the primary team. A lot of effort has gone into this in the last couple of months in terms of developing team pagers for the internal medicine services. So I think we've made good progress on this. There's still work to be done. And then lastly, alert fatigue, particularly in regards to prescribing warnings. This is something that's going to take some more time, but I can tell you we're actively engaged in this, and I'm on a committee working to try to decrease some of these warnings, so more to come on that. And with that, I'd like to hand it over to this month's resident M&M team. Peter, you want to take it away?
Sure. Okay. All right, so we have a 81-year-old female who's coming in. She had a fall last night and comes in around 11 p.m. She's complaining of right hip pain where she had fallen. Past medical history of hypertension, hyperlipidemia, arthritis, depression. She's on Coumadin, but the reason for why she's on Coumadin is unsure. And she had initially presented to an outside facility and had initial lab work and x-rays. Her INR there was 2.8. And then when she was transferred here, her INR was 4.33. So when she comes in, there's a level 3 trauma activation. I was wondering if the trauma people will be able to clarify what exactly that entails.
So level 3 is handled by the ER. The trauma team is not notified with the exception of the red shirt. And per the policy, if they're available, they attend the levels 3s. But if they're not, they're tied up with another like level 1 or 2 because that's the most serious, then the ER handles those. They work the patient up, and if they find traumatic injuries that they need to call trauma on, they will. In this case, the red shirt was present for this, and they asked the ER to call trauma, and they did not on this patient. So it was just ortho and the ER involved to begin with.
Okay. So and that's right. So ortho was paged for the consult. She had initial x-rays, which showed fractures of the superior and inferior pubic ramus, and then she was admitted by internal medicine around 2:30 a.m. So orthopedics, they saw her around 7 a.m., ordered a CT abdomen or CT pelvis stat to kind of evaluate the stability of the fracture. And the imaging was done about 30 minutes later. She did receive a prophylactic dose of Lovenox, although the primary note stated SCDs. And the CT pelvis was dictated and transcribed by the radiologist, showing that she had multiple fractures and also a large right pelvic hematoma, which was 10 by 6.7 centimeters. So the finding itself wasn't marked as critical or urgent. It wasn't communicated to any of the providers. And then we'll see it kind of throughout the day, she's receiving pain control. And around 5 p.m. is when she starts to acutely decompensate. She's becoming, her blood pressure is dropping. She's very tachycardic, also developing respiratory distress. Throughout the evening, she eventually progresses to shock. During this time, the providers are not made aware that she's decompensating in this matter. And then around 11 p.m. is when her blood pressure is 65 or 42. She's on 10 liters nasal cannula. The nursing pages the primary, who then evaluates the patient and initiated a rapid response. She receives fluids, blood. She undergoes a stat CT chest and pelvis, which then revealed that the hematoma in her pelvis had increased in volume. And she was transferred to the SICU. So the CT findings were paged out to the orthopedic service by the primary, and also her patient status and surgical critical care became involved. And their plan was to obviously correct the coagulopathy, resuscitation, and to do exploratory laparotomy. Throughout her course, she underwent multiple abdominal surgeries. At this time, though, towards day 8 and 9, is the patient's power of attorney, per the patient's will or wishes, decided to make the patient comfort care, and she passed away on day 9. So a summary of the hospital course in the case is we have an 81-year-old female who is on Coumadin that presented with a supertherapeutic INR and status post-fall with multiple pelvic fractures and a large pelvic hematoma. The INR was not reversed. She did receive Lovenox. The pelvic hematoma increased in size, which eventually progressed to hemorrhagic shock, ischemic bowel, and multi-organ failure. The imaging findings weren't relayed to the physicians, and there was no timely follow-up of the CT that was done initially. She underwent multiple abdominal surgeries, and she was eventually made comfort care.
So there is a diagram, NCC MRCP index for categorization of trauma and harm. So we have this pie chart. It shows 9 categories from A to I. A is a category which is least harmful, in which there are some circumstances or events, but they have the capacity or they have the potential to cause error, but there is no harm to the patient. All these 3 pinks, there is no harm to patient, but in category wise, there is increased risk of harm to the patient. In yellow pie chart, from category E to H, there is harm to patient, and there is an error occurred that may have contributed to or resulted in temporary harm to the patient and required intervention. In category F, error does occur, and it may have contributed to or resulted in temporary harm to the patient and required initial or prolonged hospitalization. In category G, there is an error that may have contributed or resulted in permanent patient harm. In category H, there is an intervention which is necessary to sustain the life. And our patient lies in category I, which is like green and starred. An error occurred that may have contributed to or resulted in the patient's death. So there are some teaching points. Number 1, documentation of deranged INR was very much important, and we should alert others if we see anything like this. So we should not order prophylactic anticoagulation, which we normally do on every patient we admit. Early dictation of critical imaging by the provider, and quick notification to the other providers. In our case, provider did not follow up on the results of the STAT CT scan. Also, we did not act on its finding in a timely manner. Again, notification of change in the vitals by nurses to the MDs, and also close monitoring of vitals when we see that the patient vitals are changing drastically. In our case, progression of hemorrhagic shock was not recognized early on. And the last point, early resuscitation and early rapid response activation. As we know, rapid response activation lead to decrease patient mortality. Thank you.
So teamwork and communication errors are the main teaching points of this case. High quality and safe patient care require effective communication and teamwork. Communication failures are the leading cause of inadvertent patient harm, and in a 2004 Joint Commission for Hospital Accreditation, they released information stating that of 2,455 Sentinel events reported, over 70% of those cases had the primary root cause of an issue with communication. And of those patients, 75% of those patients passed away. There are tools and concepts available to aid in communication skills, many of which have been tested and proven. In the field of medicine, it's becoming increasingly more complex and more moving parts, so communication is key. I've taken a lot of examples and tools from different areas like aviation. So we have the assertion cycle, which kind of helps a provider or somebody taking care of a patient get their questions addressed. We also have the SBAR, which stands for Situation, Background, Assessment, and Recommendation. It's used in handover and when calling a provider to give accurate information about the patient. It's used a lot in ICU handovers. So everyone makes mistakes. It's kind of inevitable. The goal is to have a team to help minimize them through effective communication and teamwork. This way you can minimize harm done to the patient. You can avoid mistakes from even happening. And when mistakes do happen, because they will, you can prevent them from being consequential. So to relate these back to our case, providers are not notified of imaging findings that required intervention. The first CT pelvis with the initial hematoma, no urgent finding on read, no documentation of informing any team members, as well as the second CT. Also, the provider who ordered the stat image didn't follow up on a stat image that they had ordered. The communication between the tech and the nurse, it was unknown who was taking the vitals, and there was not a consistent schedule in terms of those vitals being taken. There went anywhere from 45 minutes to a couple hours between documentation of vitals. The primary provider's note states that they only wanted to do SCDs for DVT prophylaxis, but they did order Lovenox and it was given.
So maybe before we move on to our fishbone, maybe if there are any questions about the case from the audience.
My question was, did they notate why they didn't want to reverse the coagulopathy?
So there wasn't any documentation about that, right? And it's interesting, that's probably why it would be good to have trauma surgery involved, because as internists, we're doing this over the whole service line, so hospitalist, internal medicine, and the subspecialists, but we don't deal with pelvic fractures a lot, so may not be familiar that pelvic fractures often come from a high force injury, and there can be bleeding associated. So I guess, do you think, can I just ask you, because you may know, do you think the hematoma was an expected finding on the CT with the multiple pelvic fractures? Should the provider have expected that and reversed the INR?
It's great, certainly a great learning. I'm Justin Calvert, I'm the Chief of Radiology. Thank y'all for having me at this meeting. But certainly a great case to review. I think there's a lot of salient points here to kind of take home. With this case specifically, correct me if I'm wrong, but there were some X-rays that indicated that there were pelvic fractures there for sure. And then a CT was done that kind of confirmed the pelvic fractures. Just to kind of let y'all know, as radiologists, our group has a system of colors. We have, which is not good for me because I'm colorblind, but regardless, it's red. There's a critical red and there's a critical orange, and we have a critical yellow, and that's really kind of how we categorize our critical findings. Basically, a critical red is a finding that a radiologist sees that a patient could basically, the risk of that finding ending their life within the next hour is very high, and we call that a critical red. And just to give you an example of what a critical red is, somebody who in the ER, if they have bleeding in their brain, like subarachnoid hemorrhage or any kind of intracranial hemorrhage, that's an example of a critical red. We immediately pick up the phone. For us, we mandate that if we find a critical red finding, we have to have a physician-to-physician conversation relaying those results. We can't have our transcriptionist just tell the doctor, the radiologist saw this. No, it has to be a direct communication between the radiologist and the provider, whether that's a nurse practitioner or a PA or a physician. And so we're very we try to adhere to that policy. And then the orange finding is kind of in between a red and a yellow. The orange finding is this is a finding that is critical. It's not a red, but something needs to be done about it in the next 6 to 8 hours. And so we'll make that an orange. And our policy with the orange is the radiologist does not need to speak directly to the clinician, although they can. And a lot of times I have so many clinicians' cell phone numbers in my phone that I'll call them directly and let them know what's going on. But if I make it an orange and I send it to transcription, the transcriptionist will contact the referring provider who ordered that study and let them know that, hey, this was a critical finding, and they will actually put a documentation in here that this report was faxed to this person at this time, so that there's some documentation of who we notified. And then finally, there's what we call a critical yellow, and a good example of a critical yellow is if I was reading an MRI of the lumbar spine and I happened to find cancer of one of the kidneys. Okay, if I found a spot where I saw that looks very malignant to me, that is something that I do want to make sure that that the provider knows about, but it's not necessarily something the patient, it's not necessarily life-threatening to that patient within the next 24 to 48 hours. And so we make those a yellow, and that way we just document that we faxed the report. There was a critical finding here, and this person received the fax, and that can even be done between office staff. Like, we just make sure the office staff knew that there was a critical finding so they can alert their physician who's working in their office that day. So the red, orange, yellow system is what we use in radiology, and I don't know if y'all know about that, but that's kind of our own policy and the way we handle critical results. This specific study, this case is really difficult because the findings of pelvic fractures were made on the X-ray, and clearly they knew there were pelvic fractures. The CT shows more pelvic fractures. You can probably see more of the hematoma associated with the pelvic fractures, depending if they got contrast or not. You can't see extravasation with pelvic fractures unless you give the patient contrast. And so sometimes on a non-contrasted study, we'll see a hematoma associated with pelvic fractures, but we can't comment about if there's active bleeding, active extravasation, because there's no contrast to comment on vasculature. So this is a really difficult. I was just kind of going in my mind, what should the radiologist have categorized this? And sometimes the radiologist, when they're reading, they're like, oh, well, certainly the clinician knows about these fractures, and we get the CT, and we're kind of confirming the fractures, something that they already know about. So should you even make that a critical red or orange? Is kind of the question. And what I have tell my colleagues is it is very easy to make assumptions and don't make assumptions. And I've been guilty of this very same case. And I don't think this is my case, but this same case happened to me a couple years ago. I didn't make the pelvic fractures a critical orange or whatever. And I think that lady she went into hemorrhagic shock. And I talked to Melanie Blake about it later on. I was like, we always but it's easy for us to assume that the doctor already knows because this is why they ordered the study. But as radiologists, I think the safer way to act is to just not make assumptions, even when they're coming from the ER, and you've got an emergency doctor ordering studies that you feel like are going to, that you feel like they're going to follow up in an emergent fashion. You should never assume that. You should always stick within your policy and stick within your reporting system, and try to make sure that there is a direct chain of communication. I like what one of you guys said, how so many errors happen because of communication. but it's really just that direct communication. And it's documented in the chart. I spoke with so and so, or so and so received this fax with this report at this time. We document all our handoffs with the date and the time in which we relayed a finding. So very good case. Does anybody have any questions for me as far as radiology goes? Hope that was helpful.
Thank you, Dr. Calvert. Appreciate that. And any other questions on the case before we do the fishbone? All right.
Yeah, so at this point, I think we wanted some group activity. You should have been handed a fishbone diagram. So this is a way we can look at cause and effect for problems and issues. With a fishbone diagram, you have broad categories that should be factors, essentially, that led to the problem at the top. And underneath each factor leading into the diagram, you can put the specifics for the case. So if y'all will break up into groups and kind of fill out the fishbone diagram, and then we'll kind of talk through it together.
And if you'll advance to the next slide to show the systems factors. So these should be your categories, right? So human error is not a systems category. So choose from these to fill out your fishbone diagram in groups. You can see.
I'll just like type it in.
How are you guys going to break up?
Is it on here?
It's on there.
Okay.
5 to 8?
Yeah. Yes.
It's on there. I was gonna. You want me to like leave it up, and then when they're actually done, then I'll just type it in. Okay. Shrimp and grits here. Pretty good.
Yeah, where'd you have it? You
It
did?
was overpriced though.
But yeah,
I
definitely.
regret it. But once I sat down, it was already too late.
I was trying to think where I would go get shrimp and grits. And I was like, I don't know, but like I had a spot, you know. There's a lot of good places to get it.
Yeah, only another dish was called sheep crabs.
Yeah, she crab soup.
Is that real?
Yeah, it's like the specific blue crab that they get down in Carolinas a lot. They take like long crab meat and they take the soup part and they pour it right on
It's like
top.
a bisque?
Kind of.
You said like it's sweeter. It's not like it's seafood bisque.
Yeah, that's what I miss. I don't eat seafood here because I'm like,
It's not the same.
yeah.
Back here. That means
one more minute. Get like one more minute.
Around and see if they all look like they're pretty actively engaged in discussion. So.
Keep thinking today's Monday. Keep feeling like it's Monday. Yeah, a surprise.
They're all still pretty actively
Good.
working.
Awesome.
Oh yeah, it changed. We're doing the Halloween party during 0 o'clock. Hope you guys have costumes. But yeah, that's right. I need to talk to you about that. So I think we should just kind of split up the one party. So one person has trivia, one person organizes a potluck, and one person does the costume party. Which I think Jamie's gonna do the potluck, so you would choose trivia or costume.
Okay.
Which one do you want?
And I'll take the mic around.
Thanks.
Probably go ahead and start with everyone.
You want to type for me now?
Yeah, I'll do it.
And did we go over yesterday? There'll be one more group activity, right, to create the causal statements
Do
and
they have
action
that?
plans.
Oh, I didn't. I thought we were just doing it like out loud, like have them make action plans. Do they have a sheet? Okay.
I mean, like, we'll get all of this into the fishbowl, and then we'll have them like
Yeah,
sit down
yeah.
and then come up with the causal
Yeah,
reasons
yeah.
and the action items.
Yeah.
Okay, perfect.
All right, you want to bring it up so we can. All right, guys, we're gonna work together and fill out this fishbone diagram. So let's start with some of those broad categories.
Do you guys have a spokesperson? Want to talk to us about your fishbone?
I'll talk to you about our fishbone.
All right.
Some of the identified factors for the training and education section were misses for the coagulopathy and the addition of Lovenox. A skill set differential between the orthopedists and the trauma surgeons in looking at bones versus other. And then just a lack of follow-up.
Good.
We had team factors related to responsibility for abnormal and worsening clinical findings, whether they're radiologic or abnormal vital signs. We should have thresholds for vital sign communication. Those were our
Good. Good. Let's get another group.
So we had kind of an overlap between team factors and training, as well as some environment. They're kind of tied into each other. One of the team factors that we kind of talked about was communication between providers, as well as between providers, nursing and tech staff, related to like what kind of vitals need to be looked at and what needs to be alerted higher up the chain.
Good.
We also talked about some of the institutional stuff, specifically talking about when she originally arrived in the ER, it being, level 3 trauma. That, the question about kind of who gets called in on that, and then just the nursing staff down in the ER as well. They have good nurses down there, but they're covering so many patients at the same time. That kind of coverage question being something that was an issue too.
Thanks.
We have pharmacy back here, and Dr. Salim is our honorary pharmacist. Some things we thought about were in terms of CPOE, or electronic medical
Yeah.
record. We wonder what time the INR resulted, and was the order for the Lovenox placed before the INR had resulted or been reviewed? If it had, is there any capability in our Epic system to actually flag the provider that there's a abnormal lab value that might affect prescribing of an anticoagulant? So maybe the provider gets alerted, patient's INR is without outside of the normal range. Do you want to continue? Just for an extra level of scrutiny. And then just as has already been said, communication issues and breakdown. Dr. Salim made a good point about when ordering imaging to provide a little bit of background, even when you may think it would be obvious. Again, like you said, we don't want to assume anything. So kind of giving the clinical scenario of why we're ordering that test so that maybe it would give the radiologist a hint about when that they should communicate the findings that you might perceive as being possibly unexpected by the ordering team. Thanks. That was Dr. Salim. And then finally, provider factors. Something should have alerted us to do a more detailed investigation of that patient's clinical scenario. We had an elderly female who had a major traumatic injury who was becoming hypotensive. So be it that the nurse had too many patients, knew she was a little hypotensive, but didn't alert the provider because she expected that to stabilize, or did the provider get notified and fail to look into that a little more closely in a timely manner. So those are a few of the things that we came up with.
Thanks. That's great.
Awesome, thanks. Yeah. You guys?
We discussed a lot of the same things that are written up there, but one thing that is always good to, or at least is kind of specific to our institution, is the transition we had from paper to electrical or to electronic medical record.
Mhm.
Is a lot of some people come in here and they have an extensive medical history, but some providers don't bother to even look back to see what's been scanned in. So I don't know how much difference this would have made, but trying to find out why is she anticoagulated in the first place. Maybe she has something in on base, or sometimes that's outside of our control. But that's one thing. If we can, I know in the acuity of the situation, there's not always time to call family or try to figure out more medical history. But that's kind of where I start off usually when I walk into a situation, as I try to find out as much background as I can so I know what I'm dealing with going forward.
You guys?
So a lot of the stuff that's already been said was more or less what we discussed as well. We were just curious, why Lovenox was given to a coagulopathic patient, and why no one looked at the CT scan until like 5 p.m. or whenever they ordered the second stat one. But other system things we talked about. We had a similar idea to the pharmacy crew, and that maybe Epic could warn us ahead of time if we're about to give Lovenox to someone who's super coagulopathic. That'd be a terrible idea. Since, I mean, Epic does that for other systems, things like the blood pressure issues, and then, if you're about to give a medicine that'll hurt the kidneys, it warns us about that too. So we could probably build in, something that'll warn us not to give, a blood thinner to someone who's coagulopathic. Okay. Yep.
Great, thank you. Let's see, who else? It's always harder on the groups at the end, so we know most of the categories have been taken. Do you guys have anything?
Hey, trauma services again. We've got a couple of things we can add. We initially reviewed the case, and we've already taken it through ACAs and different MQuICs, and there's a couple of things that we've already implemented in regards to this case. In regards to the trauma, the level 3 activations, we got all 6 of the trauma surgery attendings to agree, which alternate universe status there, that if the red shirt is involved and it feels like that the chief should get involved, that trauma services should get consulted in on that one, they can call the attending and get his opinion and get his okay. They all felt very strongly that that should occur. And also with the CTs, this was just a perfect storm in this particular case, but Notarski and the ortho group, any pelvic fracture will have a bony CT in the ED. Because in this case, it was ordered by ortho after it was already, this patient was disposed to the hospitalist, so it did go into the black hole. So we're trying to prevent that from happening in the future again.
And it did seem like from a quick literature review that all but the very simplest pelvic fracture should have a CT, I think. I don't know, Dr. Calvert, if you can fact check me on that, but we don't manage pelvic fractures much, but.
Sometimes they don't even operate on those, and they let those heal. But of course, if they're older and depending on if the fractures are pretty displaced, and especially if you've got sacral fractures, you've got a lot of blood vessels kind of running in that region, so you run risk of developing a larger hematoma. So it kind of just depends. So.
The Gels group.
Yeah, we had some. One of the things was EMR, and going off of what Dr. White was talking about, warfarin and Lovenox, typically, especially if you're adding the patient's home meds, it's going to come up as a warning that both of those are anticoagulants. So that warning already popped up, and that may be attributed to, sort of alarm fatigue, like we've discussed with the previous case as well. And a question if that was ignored or not. And if it's the patient's coming in at night, the number of hospitalists is limited, and they're admitting a number of patients. It may have just been overseen, and that might be why the reversal itself wasn't performed as well, especially with the, they mentioned when did the INR come in that was elevated from the previous value that they had. Speaking with Dr. Calvert, we were also talking about why the CT wasn't performed with contrast as well, and correct me if I'm wrong, they typically get performed with contrast, and regardless sometimes of the creatinine being high due to this. The pelvis is a large area to fill with blood, so you could start to exsanguinate, which appears that it was the case with her. And that may be a training education tool as to what's the appropriate imaging study to see. Kind of touched on with institutional issues, vital checks. A lot of times it falls to the tech, and then when we get paged about a patient being, hypotensive or something like that, we ask what the values are, like, oh, well, I don't have them, the tech does, and they have to go find the tech, and there's been a series of vital signs that haven't been recorded in Epic, so may have not been able to be even followed up on because that might have been what nursing is looking at, and the tech is carrying it around on a clipboard written down, so no one's seen the values other than the tech. So the tech knowing that they have to communicate that to the nurse and then let the provider know. So anytime you're adding another chain of communication is an issue. And we also brought up if radiology speaks to the ED, if the ED, whoever is talking to the hospitalist, surgery, etc., if they don't let them know, hey, this is what the radiologist called us about, that message may also get lost in terms of the chain of communication. The other question for institutional is adequate staffing as well. This patient may have qualified for an ICRU bed. She was a fall. She was super therapeutic in terms of her INR, But with only 20 ICRU beds, the question is, well, then do we qualify her for ICU, which she eventually required, secondary to her becoming hypertensive. At presentation, she didn't, but it's a question of, do you want the patient to incur that cost of putting them in ICU just because we only have 20 ICRU beds?
Great.
And then the only other thing was the patient factors. Why was this not clear? Was the patient disoriented when she presented? She also had a history of depression. Was she on some sort of SSRI, which could be affecting her INR as well? Did she take too many of her meds, which may have contributed to that as well?
Awesome. Thank you so much. Good job, guys. Yeah, I think we did a good job filling this out. I think some of the big things that came up were communication, obviously. That's in training and providers. And then also some of that even falls under the EMR. We talked about issues there, and the CPOE. Other things that came up, the institutional level, staffing, and then, as far as how lab values are relayed. These are all the things that we recognized as well. I think everything we kind of looked at, you pretty much touched on. So let's jump back. So again, these are the main system factors that we looked at. And then the next step is identifying causal factors. So after we have these kind of broad system factors, we want to take it more specific. So one thing you want to know is that obviously human errors, there's always a preceding cause. You can't just say human errors. That applies to everything. For a violation of procedures, you must have a preceding cause as well. And then what we'd love for y'all to do, we won't take quite as much time because we're running a little bit low, but we'd like for y'all to break up into groups again, and we'll kind of do this. You don't have a sheet for this, but maybe identify one or two causal factors.
On
the back of like your fishbone, just on the blank side. Just write down one or two causal factors specific for this case, and then maybe an action plan or an item that you think would be a good implementation based off of that causal factor. Because like we did with the previous, we'll report back on these action items and hopefully have some good news about implementation and changes that we've made. So take just maybe like 3 to 5 more minutes real quick. Mm-hmm. Perfect. All right. You want to type on the board slide, all the action items, and I'll write down the main ones.
So you go to this one there?
Yeah, and then we can just review the ones that we saw. Yeah.
Oh, no. Make it a different
There we
shade
go.
of blue.
A little bit easier to read.
Did you want to do the costume thing or the
I'll do the trivia. Unless you're
costume? I think I'm gonna make a flyer just about the costume party.
All right, let's go around real quick and just get some action items, and we'll go from there.
We'll go in the opposite order this
Yes. So give me a causal factor and kind of your action item.
So how would you?
We'd say the causal would be radiology reporting.
So we were talking about the reporting via radiology for specifically maybe all pelvic fractures with hematomas should automatically at baseline be at least an orange level to be able to at least have the transcriptionist alert the physician who ordered the study, regardless if a previous study noted fractures before or something like that. The other thing was what I was mentioning before in communication in terms of vital signs. A lot of times, those vitals will be sat on for some time, and this may have been able to head it off at the pass, maybe some more prompt intervention in terms of the coagulopathy or, resuscitation efforts could have been earlier if those vital signs may have been transferred earlier.
Great.
Great. And maybe on the hematoma, would it make sense if it's just a new hematoma in general for that to be in orange? Is that something reasonable, Dr. Calvert, maybe? Okay. Can you be our champion on that since you can easily make that happen? Okay, we're putting you down. All right, awesome. Thank you. Do you guys have anything to share?
I think I jumped the shark and did that last time. The changes that we made.
Okay. Yeah. Awesome. Anything over here?
Pretty much sums it up.
Do you guys have anything?
Just one thing, I'm not sure if we can put an action plan, but I guess as a physician, we have to go back to our basic skills. We don't necessarily need to depend on nurses to get like vital signs. So this lady basically went to shock. She's an old lady, fracture, coagulopathic, went to shock without anybody noticing that. So when she went to shock, most likely she lost more than 30% of her blood volume without any of the physician noticing that lady. She's getting pale, she's tachycardic. So I think we should get to the habit to check at least the pulse and the clinical picture of the patient, We have to have very high clinical provisional diagnosis and suspicion. So when we order stuff, basically to rule it in or rule it out. So I guess getting back to our basic, it's very important. I don't know how to make an action plan.
No, that's good. That's definitely something doable.
And I think we do have to rely on nurses to be our eyes and ears because we don't, we're not with the patients all the time. Right. And so I think the second and third points probably go together. And we may need to get with nursing to ask, are there specific parameters where a nurse should be required to notify a team about certain vital sign changes? And if we don't have that may be an action item that's reasonable, because there have been multiple cases lately where maybe a PCT has observed vital sign changes, not let a nurse know, or the communication's not gone to the physician. So that's probably something that we can look into with nursing leadership. Would anybody want to be the champion on that item? And I can help you with that. All right, Megan, awesome. What about you guys?
So we were just wondering, maybe a failure to follow up by the primary team. I'm guessing this was admitted by the internal medicine team. Was it overnight or?
It's just the medicine service line. We're not disclosing which service.
So I'm assuming it's the medicine team. So at least we should, if this was is a patient that we were following up overnight, at least, somebody should be following up on the scans, or maybe just, even on Epic, they have documented blood pressures and stuff. I'm guessing she came in with the normal vitals and overnight kind of went down. So just to re-educate residents and or maybe interns to follow up on their labs, and maybe we could have averted this. This is just a side note, so I'm wondering how was this communicated to the family, given that we had a mortality case on this one? Did we?
That's a great question. I do not know. Typically, that's not something that is documented in the chart. So as, chart reviewers, we don't know how that disclosure went, but that's a really good question. And probably at some point this year, we need to talk about disclosure in one of these conferences. Great.
Well, we wanted to see if there was a I think one of the causal factors may have been admitting this patient to medicine instead of trauma. And I wanted to see from those guys' perspective if they thought this lady would have lived if she had been admitted to trauma.
A heated question.
No pressure, not on the spot at all. This is what we do day in and day out. So yes, I think she would have had a better shot if she had been admitted to trauma services. We're just trained to look at certain things and keep an eye on certain patterns. We have usual suspects of injuries. So, I mean, in all honesty, yeah, I do.
So is there a threshold of trauma at which it should be admitted to trauma?
No pressure, not on the spot. That's something it's a system-wide issue that we are working on daily. Trust me, we're looking at our over and under triages. Every month, we're looking at our criteria to see, do we see patterns? Can we tweak? There are certain things that the ACS we have to keep in, but there are certain things that we can be hospital-specific, and we have made changes, and we have seen improvements. But we're working on it.
Thank you. Sorry for the pointed questions.
And it sounds like from the surgery side of things, and orthopedic side of things, through the MQIC committees that this has gone through, some changes have been made, such as all pelvic fractures are getting a CT in the ED. I think I heard you guys say that. And then I heard from, I believe it was Dr. Dart, who said all pelvic fractures with hematoma are going to get a trauma consult as a standard. So a couple of good changes in process have already been made. And then you mentioned that you guys can now elevate any case to the trauma chief, which is a good change as well on that side. Awesome.
And I think in this case too, because I was the one that wrote this case up, when it initially came to our attention, the nurse and the tech both charted the vital signs in MAU. So I think that's kind of where it started to go downhill, because nobody reported those to the physician, nurse practitioner, so nobody was aware. So that's one of the, and I know that has went through and has been handled.
All right.
Awesome. So just in review, a few of the causal factors that we kind of identified ourselves were just essentially there's a little bit of confusion when you do the chart review as to who was established as the primary team. We kind of talked about this. The ED should have paged trauma, but it sounds like they just paged ortho, and ortho didn't see them till the next morning as a consult. So there was a little bit of failure there. We also had failure to communicate urgent and critical imaging findings, especially when something is ordered. Stat, it should be followed up right away. We had the failure to recognize a patient who is decompensating. Again, I think we all identified those issues, and looks like they're already also being addressed. And then we had failure to utilize appropriate guidelines with the DVT prophylaxis. I think in the note it says SCDs or sequential compression devices, but the Lovenox was still ordered and given. And then we also have failure to recognize a risk for pelvic hematoma when a patient presents with pelvic fractures. That probably would have helped as well. So I liked the action items we kind of came up with. I think we have two really good ones. Maybe even have room for a third. So the first one we talked about making all pelvic fractures with a hematoma an automatic orange, so that the imaging results get at least sent to the transcriber, who will then fax them. Next, we have the vital change communication. So working towards maybe coming up with a more standardized way of communicating vital changes, certain drops in systolic pressure, certain changes in heart rate, trigger an automatic protocol for nursing to call the provider. And I think Megan's going to follow up with that. And then I think I liked the last one that Ibrahim kind of gave, the follow-up with stat imaging. I don't know, maybe the action item is just if we order something stat, we have to leave a comment that we reviewed the stat result imaging. You know, if I order a stat MRI, somewhere I can just document MRI reviewed, no finding, or there was a finding and now I'm following up with a neurology consult or whatever it might be. So that might be an action item I'm going to take charge of working on. So
And I think there was also an interesting action item mentioned during the fishbone, which was about ordering anticoagulants, that we should have an INR notification, potentially. We should be alerted, just like if you order contrast and someone has kidney disease, it alerts you. Maybe there's a way in Epic, and we could potentially explore that. All right, Brittany's on.
Awesome. Thanks, Brittany.
Okay. All right, thank you guys so much for coming, and we'll do this again in December.
Yeah, thanks, everyone. Well, just make sure.
Team C.
Yeah. Now we're down to big action. I wasn't sure.
Joshua, how are the kidneys today?
Mine are fine as far as I know.
Are they failing all over Erlanger Hospital right now?
I have a couple that are on the mend.
Good deal. Good deal. Oh, this college student's been staying with us for fall break. It's a Barry student.
Oh, really?
Yeah. College students stay up late.
I was in bed at 7:45.
Yeah, that's what I wanted to do. That's what I was wanting to do.
No, like, it's weird, man. It's worse now that it's dark. I wasn't even that tired last night.
Yeah.
It was just like, well, it's dark, and the kids are in bed. I guess I'll go lay in bed and read.
Yeah. And then it's over.
Quickly tired.
And then it's over. And then it's over.
The heart of darkness.
That's like just like deadlift today. Oh man.
If that one's not your description, then you're pretty tired, probably. Need to go on to bed. Hey. All right, man. Have a good day. See you later. Oh yeah, we're just going to follow him up on Mr. Costello. When does he want a line? What line does he want? When does he want to see?